All right. So good afternoon to our listeners all across the African continent and the diaspora. My name is Benjamin Akwe. Thank you for joining us today for this edition of the Komfo African webinar. Today is February 28, 2025. We are happy to bring you this program today. Normally, we do not talk about internal political issues. Most of our issues are mostly national issues, and it has to do with conflict and things happening around the African continent. But we have this unique situation where we want to have a conversation in terms of what happened with the president's State of the Nation address and look at other issues or other controversies that I'm very familiar with. The purpose of taking today's topic is what is happening in Ghana, something that I'm very, very familiar with. Even though most of the issues that we've been discussing over the years has been from one country to another country, but today we want to focus on what is happening internally. We don't want to do a lot of politics, so we'll switch to look at the main issue, which has to do with the healthcare sector. Right. So today we are very, very fortunate. The title of today's program is the President's State of the Nation Address and the Controversies Surrounding the Agenda 111. Right. We are fortunate today to be joined by Dr. Nsiah Asare, a man that I've known since 2029. I've been engaging for a while, right? He was the former Director General of the Ghana Health Service. He also was the former presidential advisor on health policy and also the CEO, the former CEO of the Komfo Anokye Teaching Hospital, right? So, Dr. Nsiah Asare, you are welcome to the Komfo African Affairs program.
Thank you, sir.
All right, so what we do, today's program is kind of a little bit different. What we normally do is that we do a little bit of research. We create what we call narratives. The narratives are based on research, policy positions, and realities prevailing in African countries. But given what we are discussing today, you are aware of the issues already. I've also been aware of the issues already based on my engagement with you so over the years, right? So we'll get into that. But before we get into our discussions, right, I'm going to make a brief statement, and I want you to complete the brief statement, right? So the state of Ghana is, if you have to complete it, what would you say? The state of Ghana is, if you have to complete that statement, what would you say? Based on the president's address yesterday, the state of Ghana, from your perspective, is what?
I would say that the state of Ghana, we are still developing.
Okay, the state of Ghana, we are still developing. Okay.
Yes.
Yeah. Since your expertise is in the health sector, the state of the health sector is, can you complete it for us?
I believe the state of the health sector is on a good it's moving from what we used to have before. And I think we have also improved considerably so far as the state of the health sector in Ghana is. We have been better than what we have now, but I believe that compared to other developing or lower middle income economies, I would say that we are moving in the right direction.
All right, thank you very much. Right, so still, let's keep discussing some of the issues. I want your comments on certain things, right? Recently, there has been an outbreak of cholera. Then we've seen an outbreak of meningitis, right? So what are your thoughts on these two particular issues?
I'll start with the meningitis. Meningitis is seasonal, but around this time from January till the first rains come, especially in the northern part of the country, cerebrospinal meningitis is something that you see. We have a very robust, well-organized public health systems because I've worked there before. I've worked in the system before. We operate from bottom-up approach, from the community level up to the national level. So disease surveillance is very well structured in Ghana. And when these diseases start, we have not been able to clear it completely because of our socioeconomic situation that we have in the country. But I believe that we look at these diseases and look at the fatality rates, and then see that I believe that of time, if you continue doing what we are doing and do it properly, and we don't have to slack in anything, we'll reach where we want to reach, so far as public health system is concerned. Cholera. You see, cholera is basically people, excuse me my language, eating somebody who is infected feces. It's as simple as that. So anywhere there is a problem of environmental cleanliness, people are not washing their hands, people are not cooking their food, people are eating raw food, which the water that is used to irrigate or water the vegetables are contaminated, then there's a problem. If you remember, during the COVID period, from about early 2020 till the late last year, we didn't see any single case of cholera. We had cholera outbreak, I think, between 2012 to 2000. It was very much at its peak in 2014 and 2015. Normally, there are some, it's a bit cyclical. Maybe the public health epidemiology will tell you that almost every 5 to 10 years, we may have it again. But when we had COVID, I believe that COVID was a kind of it was a problem, but in disguise, we also, as a country, and even as a global economy, we all learn how to at least keep to environmental sanitation and then wash our hands and then use sanitizers when you cannot have water to wash your hands. And that period, we didn't have any cholera. We were scared, we were afraid that if you are not very careful, and cholera comes in addition to the COVID that we had. But what happened? There were vertical buckets all over the place. There were areas where people were washing their hands publicly, in all public places. If you are going to the bank, you are going to any public place, hospitals, you wear your mask and then also wash your hands. We should have continued with that. But immediately, we declared that COVID is no more public health emergency of international standards, and then we declared that the COVID has subsided. So we are going to live normal life. The first thing we saw was that the vertical buckets, which were situated at various strategic places and vantage places, all disappeared. If it didn't disappear, there was no water. You see dust around it. The soap that people put around their offices and their stores and their other public places of where people go will also disappear. People will stop also wearing even their mask when they are even coughing. So to me, we should have continued that. If we have continued that, I'm sure maybe the small few strains of cholera which was hovering around would have gone. So if you realize, the recent cholera outbreak started during the heat of the elections. Okay. And you can only fight cholera effectively if the local authorities and the political authorities are also part of the fight, because they have to provide water for people who need water. They have to provide places of convenience and everything. And that is the reason why when it started at Sekandi Takoradi municipality, we had some deaths and they started spreading to other regions and other districts. First around Sekandi Takoradi, a few came to Accra, I think Kaswa area, and then I think they have about 5 cases in Kumasi. So this is how it is. So cholera should not be something that you should be now be experiencing. If you follow strict environmental sanitation, we also continue to give places of convenience and then let everybody have drinking water which is safe and clean. That's what I would say about the cholera outbreak.
Yeah, I'm bringing some of these issues because of your years of expertise. So I'm just trying to get some information out to help people out, right? So thank you for that. Now let's go to this one. I want to put this in across, right? USA, Trump cutting the USA funds. How would that impact the Ghanaian health sector? Given your experience, I think I learned the amount involved was almost like $175 million or something like that. How is that going to affect our health sector?
Yeah, I think it's so abrupt, it's so sudden. So it didn't give any country, especially the lower income economies and the developing countries where USAID was giving a lot of aid, didn't give us any chance to even prepare and put it in our budget. Luckily, in Ghana, we are now going to do our budget. So I'm very hopeful that the government will put something to bridge the gap, because they are doing a lot of things, a lot of projects, especially in the northern part of the country. And it's not very palatable, but I mean, as we have always been saying, we should be a country who should be now be living beyond aid. So maybe this is going to force us to put money where it's supposed to be put and cut down a lot of expenses so that at least you can keep the people safe, because health is wealth and there's wealth also in health. So if you keep the people healthy, then I think apart from health, they are also in other socioeconomic aspects of the country. They are also assisting in other aspects. And it's something that we didn't want to hear now, and but it has come. So I think we have to live with it and then make sure that we mitigate the effect.
Okay, all right. Thank you very much. Right. So I just want to put on record, right, that sometimes we on this program we do not want to get into data and figures which are churned out by political actors, because we know sometimes some of the numbers are being massaged and things like that. So we will not get into those areas where this person is saying this and this person is saying that. Mostly we would like to do our own research to get out the figures itself. So the president said so many things yesterday and the week before. I don't want us to get into other stuff. But you said something very, very interesting. You said Ghana health sector is bottom up. What do you mean by Ghana health sector is bottom up?
Yeah, if you look at Ghana health sector, the health delivery system that we have in the country, I don't think it has been classified anywhere, but I classify it into 5 tiers.
Okay.
You know, we have we have the community-based system, which is a community health planning-based planning system, the CHIPS.
Yes. Okay.
So we have community health nurses or community health workers at the local level. Normally, what they do is trying to do health prevention, health promotion, and then also education and the minor treatment of minor ailments. And in some places, also antenatal care, maternal and child health. That's the concentration. So that's the basic system. We have different types of the CHIP system at the community level. We have some of places, we have CHIP compounds, which look after a number of people within the community. And then some places we also have CHIP zones. They operate from maybe the sub-district level and then move there to give health education, do weighing of children, give immunization and other things. So if you look at our immunization levels in the country, it's very good. It's one of the best, because we immunize, we try to catch every child, we catch everybody who's supposed to immunize, and make sure that we reduce maternal mortality and infant and neonatal mortality. And even we have also added some aspect of mental health education and mental health screening and the rest. And then you come to the second level. The second level or second tier is the sub-district level. Mm-hmm. So when anything happens in the community, the action is done at the community level. Mm-hmm. And then it moves to the sub-district. The sub-district is where the health centers, polyclinics for clinical care are. And then we also have maybe a few of them. The polyclinics have some few doctors, 1 or 2 doctors. And it's normally manned by physician assistants, public health nurses, community health nurses, and the nurses, and the disease control officers. Okay. And then we have the district health systems. The district health systems then control the whole district. So we have a few sub-districts like the electoral area system. And then we have the community level, which I can maybe equate to about maybe the police station, if you look at the political angle. Okay. So the district level is one of the most important, because most of the people live, anybody who lives in this country lives in a community. Right. He lives in a sub-district and he lives within a district. Then we have the regional level, where we have the regional health directorate of the regional hospitals, where we have the secondary referral center. So the first primary referral center is at the district level. And once it is strengthened, and then the base is also strengthened, now Ghana Health Service has introduced what we call the network of practice, so that there will be a seamless assistance to the lower level by the higher level, that is by the district and the sub-district. They will take care of what is happening in the community, monitor whatever they are doing, and also make sure that they also have readily available data for planning and budgeting purposes. And then the regional level then oversees all the districts within the region. With and that's where we have the secondary referral centers on hospitals. That is, we call the regional hospitals. And then we have the fifth tier, which is the teaching hospitals and the specialized hospitals or the quaternary hospitals. So if you look at it, it's just like 5 steps or 5 tier that you use. And because of this, we are able to do a lot of interventions at a very short notice. We are able also to control the supply chain management system, the logistics system to all these areas. And recently in 2019 or 2018, with the introduction of AI into the supply chain management system through the drone system, we can then even go to areas where hitherto when it rains, because not all the roads in Ghana are asphalted. So in the rural areas where there are problems, where the drones are can then deliver very vital, essential vaccines, anti-snakes, and other emergency medicines at a very short notice. For example, if somebody has a snake bite, that you have to go around looking for anti-snake from this hospital, but now some of them are stored at the distribution center. If you go to any of the 6 drone distribution centers, it's like a complete supply chain management area with -80-degree refrigerators. In fact, when we were doing the COVID vaccination, when we had the first Pfizer and then the other very cold vaccines were coming into the country, the problem that we were thinking about is that where do you have -80? They were only in few teaching hospitals and research centers. But God being so good, there are some in the drone distribution centers, and they delivered over 2.7 million doses of vaccines, COVID vaccines. In fact, there are areas where hitherto what was going to happen is that sending even the vaccines there was going to be a problem. That they have the highest percentage utilization of COVID, and we vaccinated more percentage of population than even in the urban areas where people were reluctant to go for the vaccine. So that is it. Apart from that, there's a disease surveillance unit at the Ghana Health Service headquarters. Also has a lot of disease control officers across the country in the districts and the regions. We have specific also disease control units also, which is in Accra, and they have also look after whatever is happening in the districts and in the regions. We have the coordinators and the program managers. We have also coordinators in the district, in the regions, which just said disease control and also maternal and child health and the others. So that's how our system is. That's why I say that we have a very robust public health system, which we will have to continuously improve it using electronic system and digitization so that we can easily see what is coming into the country, look at what is happening around our borders and also globally, and then we can take action as quickly as possible.
Sure, thank you very much. So from what I'm getting, we have 5 tiers, 5 different layers: chief's compound, sub-districts, the districts, the regional, then you go to the teaching hospitals, right? Now we're talking about the universal healthcare, which is 2030, right? Now within these 5 tiers, what would you say are the challenges in this 5-tier system that we have, healthcare system? What are some of the main challenges in terms of access to healthcare?
The main challenges to access to healthcare, to me, is finance. You see, if you have geographical, there are 2 types: either geographical accessibility, and then together with geographical accessibility, you should also have financial accessibility. Because I've always been saying that you can have a very beautiful health facility, and if you don't have any means to go inside the facility, it will be like you don't have any money and you always walk in front of Golden, now it's a Lancaster Hotel or Movenpick. I say, this is a very beautiful building, but I cannot enter, or you don't have the means. In Chi, we say the Acadian in the So that's how it is. So in 2003, when we passed the law for the National Health Insurance Scheme, and then from that time, only few people were doing it. And then our National Health Insurance Scheme is a very unique social insurance scheme because it's basically the amount of money, the most money that they use for the reimbursement is from taxation, the direct taxation. So I've always been saying that we should continue strengthening it and even bring private sector also to come into health insurance so that those who want to use private sector as health insurance use, so that we have to maybe have a regulator which will regulate both the national one and the private sector. So that everybody in Ghana, if you look at the law as amended in 2012, it said that everybody in Ghana shall, and the lawyers will tell me, I don't know if you're a lawyer, that if you put shall, it means it's mandatory.
Mandatory, yeah.
Yeah. So if you look at the amount of money that a few people are paying to renew their health insurance, it forms only a very small percentage of the health insurance budget. The National Health Insurance Levy, which is the direct taxation that everybody pays, forms about nearly, if I'm not mistaken, it's about 97 or 94, 96%. But even that one, because there was some capping of the national insurance levy, if the capping is not there, it will be very, very negligible. So I believe that we should slowly remove the capping because if I have a water here, which I'm holding, anytime I buy the water, I pay national insurance levy. So why should somebody go and pay extra money before he belongs to an association that he has been contributing to? That is my argument. Okay. And I think that we should be able to make it universal that everybody in this country, even foreigners who come here, should take some kind of insurance into the national health insurance scheme so that at least health insurance can take care of, so that the financial problems will be sorted out. Since we started implementing national health insurance in 2005, I was in Komfo, and I was in Komfo when we were doing the cash and carry. I could see that there was, for example, one ward at the maternity ward where we're keeping patients who have gone through, who have come for cesarean, simple cesarean section, because they couldn't pay. And I was always saying that they will lie down there until their children can bite them. They can bite meat. Sometimes some of them stay there for about 3 months, and we use the social welfare to then let them go home. Yeah. But immediately health insurance came, especially immediately the free maternal care came in. The ward that we were detaining these patients was empty. Now the ward is used for family planning activities. And then when we added children below the age of 18, the children which were also detaining children because they are responsible parents. The father will not come there to come and pay. And they leave the children there, it's the mother. So we have to go and sign them up. The children ward also was cleared. So I believe strongly that health insurance should be continuously be strengthened. And once you strengthen it, it means all the money that we get from the National Health Insurance Levy to be made accessible for health insurance. And health insurance can then put in money for the healthcare delivery and even improve the facilities in the health hospitals. That is one. Two, the next one is accessibility, geographical accessibility. That's the reason why maybe Agenda 111 comes in. I believe of the national network of practice so that we have the base and we have a proper referral system, and then every district has a very fit-for-purpose, state-of-the-art first primary referral center who have the quality of care in the country very, very good. Because now health insurance have added a lot of things, for example, non-communicable disease. So now they are seeing sickle cell patients, giving them accepting. Children of 4 major childhood cancer disease have been taken care of. Even family planning has also been taken care of. And recently, I was so thrilled and happy that mental health, the 4 major mental health service conditions, has also been taken over by health insurance as part of the basic things that they look for. So if you all assist and make health insurance become robust, and as the economy grows, I'm sure health insurance can take, and also recently also dialysis.
Okay, yeah.
Patients of dialysis. But I believe that that's not the end. You should also look at the other aspect of patients who are having chronic diseases. especially lifestyles have changed.
Mm-hmm.
And it's not only dialysis, but dialysis, and they should also try and pass the law, because it's a policy which we have to pass through the law, what we call the tissue organ donation transplantation law, so that once you take you are on dialysis, you prepare yourself for also renal transplant. That is the end treatment of chronic renal failure. If you are even a billionaire and you go on dialysis 2 times or 3 times, maximum, maybe 2 times is where they can pay, maybe 3 or 4 times a week, for 10 years, you become a pauper. So that's the way to go.
Let me step in briefly. For those who are listening to us, right? We want Dr. Nsiah to educate about the healthcare system. We'll come to the agenda one later on. But we want education, because if we understand the education, then when we get to agenda 1, that's when you see me posing my questions, right? But okay, let's go to the issue. What is the doctor-patient ratio, and how you, given your experience, right? What steps were taken to resolve issues about lack of medical doctors being posted to rural areas, doctors refusing to go to rural areas? What steps were taken to resolve some of these issues? Because you are talking about accessibility, right? So what steps have been taken so far in terms of the doctor-patient ratio, 1, then in terms of having doctors go to rural areas where most of these communicable diseases come from?
Yes, doctor-patient ratio, I'll compare it to when I was a medical student and I became a doctor about some 40-something years ago.
Yeah.
We were very few doctors. In fact, that time we started medical school where it was only University of Ghana Medical School, or Legon, which was training doctors. In our class, we were only 65, 10 dental students and then 55 medical students. The following year, the School of Medical Sciences, Kumasi, came on board. And now I'm happy to say that there are about 5 medical schools training doctors, which is good. Yes. But the capacity to train more doctors may be there, but we don't even have facilities to do their clinical training properly. So they are restricted. Students of grade 8 and 9 don't get chance to go to medical school. There were some few students who were going to China, Ukraine, and the rest who normally come to join. So I can say that as a country, if the last time I look at the records of the Medical and Dental Council, I think we have nearly about 10,000 plus doctors in the country, but we need more. So if you continue using the same method that we are using, then we are going to take a very long years to produce the number of doctors that we need. 2, once we are training them, we should have a means of employing them. I'm now on doctors. I'll go to nurses. So now there are 2, or I think there are 3 private medical schools. 2 of them have started producing doctors, plus the 5 medical schools in Kumasi, Accra, Cape Coast, Tamale, and Ho. They are the public schools. And I've also heard that Sunyane is trying to also start the medical school training. But all needs place where they can train these young students. That's the reason why we need more hospitals as clinical training sites. The second point is that once we have finished training them, and nurses, we have a lot of nurses trained. And I'm happy that now nurses are also going into degree nursing training, and also even postgraduate nursing training have also started in Kumasi and also in other places. And I've seen a few nurses who are also PhD holders who are at the clinical bedside. So looking at my years back from since I became a doctor till now, I think we are moving through it. Nurses have moved even faster because the nurse to population ratio is around 1 to about 500, which is not too bad, which is within the WHO thresholds. But the issue is that, are we employing trained nurses who have trained about, last time I have a look at it, I think about, is it 50% or 40% of them have not been employed? Because the reason being that it's only the government, the public sector is the main employer of healthcare professionals. If you look at it, the public sector, I mean, including the Christian Health Association of Ghana, the church institutions, the government employs for them. But the private sector is still circulating and using the number of health professionals that we have in the public sector. The other thing is that the distribution of our health professionals, both nurses and doctors, is more skewed to the urban areas, especially the last time that we had a look at it. I think Greater Accra alone had about 48% of the total number of doctors who are within the public sector.
Correct.
Whilst if you go outside to Northeast, to Upper East, Upper West, and there are some hospitals where there's only one doctor manning the whole district hospital within the this.
Correct.
Worst of it all is also the distribution and training of graduate or resident doctors. So Ghana College of Physicians and Surgeons has now decided to also decentralize the postgraduate training. I believe that that's the way to go, because postgraduate training, yes, there's didactic aspect of it. Now there's webinar, there's Zoom as we are talking. In the morning, anybody can access it.
Correct.
And there's more work at the district and the regional level than in the few teaching hospitals where they are competing. The third point is that I believe for doctors, the few consultants and senior specialists that we have should not be only consultant in one hospital.
Okay.
If you go to UK, somebody is a consultant in about 2 or 3 hospitals. The same thing with US. So we should be able to also appoint within the system so that we take some kind of exception from the public service system, that health professionals can work and collect extra money if they have to use their time, maybe 4 hours a day extra, and they should be paid from the payroll, because we are deceiving ourselves that we are behaving as if we are taking care of them. So if you don't take care of people, then they will leave the country.
Okay.
So now the brain drain is also affecting, especially post-COVID, when most of the developed countries need a lot of people to come and assist them. You cannot compete with them, but we should mitigate the brain drain so that the push factors are minimized. What are we doing with the few ones who are in the country? We introduced, when I was in Ghana Health Service, in 2008, we introduced what we call the electronic placement system. Because we didn't want any human interference in postings. So we were not saying that, you see, if you get somebody is looking for a job, say, I've posted you. Maybe he doesn't want the place, he doesn't want to go to the place. So why do you post the person to the place? So you go on the net and you realize that these are where the places that we have vacancies. Then you apply. It worked very well. It was working very well, but as usual, there are some few hitches here and there. So that's what we introduced, and we have to better it and then make sure that we do it without any human interference, without anybody coming to tell you, I want my son or my daughter to be at Achimota Hospital. Why? That is where my house is. Once you are doing that.
Let me ask you something very interesting. Then we'll start digging into the agenda 111. When you use the word access to medical care, right, I want to understand it. Does it mean that, is it a care, there's a difference between care and access to medical doctor? You can have care which might not necessarily come from a medical doctor. You can have, like you said, community health workers treating somebody at the local level. That is access to care, but it is not access to a medical doctor, right? So can we say that all those people below, all the population below the district level do not have access to medical doctors?
Yes, you have said the right thing. I mean, access to health care is not necessarily access to a medical doctor.
Correct.
There are some things like any other places. There are people who are doing the work, which when it is above them, they refer. That's what we do in the health system.
Correct.
So access to healthcare, for example, immunization is access to healthcare. It's not done by doctors.
Correct.
Giving injections is not by the doctors. There are people who are trained to do that. Some people, they do it, some of them do it even better than the doctor giving injection to you. So that is how it is. So there's a difference between access to medical doctors. And even if you go to the access to the medical doctors, there's also a differentiation. Is it access to a general medical doctor or family physician, which should be basic so that everybody have it? But there's also access to specialized care.
Correct.
For example, somebody who has a very specialized disease to have an easy access by referral to a specialist. That's what I'm talking about. Specialists also having privileges in other health facilities, if it is public or charged or anything, which will be paid for so that he doesn't have to hustle for it. So that is the problem.
So does it mean that because all those people below the district level do not have access to medical doctor, we are not able to detect diseases early before they escalate to the district level, which leads to what we call congestion at the regional and teaching level, teaching hospitals.
Yeah, that's the reason. That's the reason. Yes, you can say that in some districts. That's the reason why we believe, and which will come when we come to Agenda 111. We tell you why the president did that. We believe that one of the most important access to care that you should have is access to primary care at the first primary referral center. It's very, very vital. So that not everybody moves from CHIP center straight to Kolebu. No, it's not done anywhere. If you want to see your doctor in any specialist hospital, it's through a referral system. And you are referring doctor. If you UK, for example, the primary physicians or the GPs are very, very important.
Correct.
They are the holders of the National Health Service Fund. If you go to UK, the same thing. The primary physicians are very, very important. So that's how it is. But in Ghana, because some areas we don't have doctors and everything there, we use health centers. That's the reason why we want to get district designated fit for purpose modern district hospitals, which can also train in every district. They also need to have access to a doctor, access to a proper doctor in the district, so that when physician assistants, when the community health nurses, when the public health nurses, when the nurses or anybody sees the patient, he knows where to refer to, which is not far from where the patient resides.
Right. So is it fair to say that almost like 40% of Ghanaians who probably live below the district level do not have access to medical doctors? Can we say that?
Yes. When we did the vice president office and the Ghana Health Services people did the research, and they came out with the 88 districts without hospitals. That's exactly what is it. Even as of now, we've been going around.
Let's get to the agenda. What went into the conceptualization of the Agenda 111?
We see Agenda 111 is out of what we saw during the COVID period. Remember, during the COVID period, patients who had the COVID, initially there was a problem of even the fear of the unknown, because something that we all didn't know. But those who had it and were sick were looking for beds for them. There were no beds. You see, COVID was not just like cholera, where you can make a tent and put anybody there. It affected the respiratory and then all the organs. So most of the patients even needed not only ordinary hospital beds, but high dependency or critical beds. That time, the only place that you can have critical beds were in the teaching hospitals, even very few of them, and maybe 37, and the UGMC, and then also that's why we opened UGMC quickly. So what Agenda 111 did was that the president, when the vice president came with the report that there are 88 districts without hospitals, so quickly we sat down and we realized that there are even some places where they designated them as a district hospital. They are not hospitals. For example, I'll give you an example. Mankranso in the Hafuano South West District. It was a health center, which was upgraded to a polyclinic, which was then designated without any upgrade to a hospital. And then, because we wanted every district to have at least, you can designate one, either a child institution or any hospital. And then half of it got bent. Do you call it a hospital? No. So we have to give them one. So when we added it up, we then have about 101 of the districts that we think they have, because there are some districts which are very wide apart, far apart, and if you look at the geographical distribution, some of the population lives in one wing, the west and the east have another population, so we have to put two over there. But I will quickly add that people think that Agenda 111 is the only health facilities the previous government by Nana Dankwa Akufo-Addo put up. I can tell you of confidence that Nana Dankwa's government initiated and finished 47 health facilities across the country.
We'll get into all these statistics, but
I'll come there. Yeah. So that's the reason why.
Hold on. You said something very interesting. You said a research was done where you realized that there were 88. There were 88 districts did not have district hospitals, right?
Yes.
During the time of COVID. Is it fair to say that then the action was reactionary? I don't want to use the word knee-jerk that the president used. There was a research which showed that there were 88 districts without district hospitals. So you decided to do something like that. Does it mean that that decision was therefore reactionary?
I don't know. I mean, maybe you can say that, but it was, if it's even reactionary, it was a very good reaction.
Correct.
Because, you know, the president was always saying that we want to turn this crisis into opportunities. Remember,
Right.
it's one of his great speeches that he made. Apart from that, I can bring the economy back, but I don't know how to bring a human being back.
Right. Yeah.
So we're learning lessons from whatever happened from 2020 March to 2022, when we declared it over the 2 years period. It was a very, very, very dicey and very tiring and problem. We couldn't sleep. Every time everybody is calling you, doc, I have somebody here. Can I get a bed for the person? So yes, we react to issues. When a problem comes, we have to react to it and react to it very quickly. And
yeah,
that is why.
The interesting thing is that I'm having a conversation with you and I'm using the word reaction, which most of our listeners over here would agree to some extent. But if the politician is using the word knee-jerk, I think that the word knee-jerk tends to be a little bit demeaning.
I will not accept knee-jerk. Knee-jerk means that
the word reactionary.
Yeah, we are reacting. I will accept the word maybe reacting to a very important and dying situation. Right. But I won't say it's a knee-jerk. Knee-jerk means that you didn't even think about the future.
Oh, okay.
That's what I take it. That you reacted because you didn't think about it, because somebody is hitting my knee, so you remove the knee, and then you put the knee back there. No, you remove the knee, and then you put something there so that it doesn't hit you again.
Okay,
that's the situation.
Let me prove further. So the research was done probably somewhere around 2021, if I'm correct.
The research was done, yes, the early part of 2020. No, in 2020.
Okay, 2020. So the
decision. 2020. In fact, during the peak.
Okay, the decision to construct the 88 hospitals was done in which year?
In 2020. I think it's one of the, if I knew, I would have brought it. It's one of the president's nation address. Then he mentioned that we found out that, you remember, it was first called Agenda 88.
88, correct.
That we found out that there are 88 hospitals, and I'll make sure that we have fitting hospitals for all these districts.
Correct.
So then we started the processes. It went through about 1 year thinking processes of the consultant coming out of drawings and all these things. And even the human resources who will be working in, we did everything, which we have sent to Ministry of Finance, which it is on their table, that anytime any of the hospital is ready, they know the number. For example, we knew that if you want the hospital, this hospital to run effectively, we need about 550 workers, both health professionals and mostly health professionals. And we knew that for the regional hospitals, we need about 1,350. The psychiatric hospitals, we need about 947. That's why we boldly say that Agenda 111 will create about 70,000 very useful jobs for our youth. So it was well thought of. People think that it wasn't thought. We didn't think through. We'd use over a year to think through before the president cut the first sword to start the construction of Agenda 111.
All right, thank you. So initially it was 88, now 111. We're still in the COVID. So COVID ended somewhere around 2022, right? So let's stay from there. Now, as of 2022, you had only 2 years of the Akufo-Addo administration, 2 years, and you were thinking about constructing 111 hospitals. That is never feasible, never ever, right? So are you resting on the assumption that government is a continuum? So if you start and you do not finish, the next government was going to do that. But let me bring to our sense, historically, what we have known in Ghana historically, no government starts a project, does not finish it, and the other government comes to complete it. That is a fallacy. We've seen that has happened already. So why were you so rational that if you start and you don't finish, the other government is come to start? What was your motivation to have that
We're
kind
doing
of
it.
thinking?
Yeah, we started Agenda 111 on the condition that government is continuing.
Right.
2, you also said something that when one government starts something, it's not finished.
Yeah,
that
historically,
one,
we've seen that
historically. But I
right.
can tell you that the previous government came to meet projects which were started by the government from 2012 to 2017 January. We finish it. Those that the money can finish, we finish it. For example, I'll give you an example. The NMS projects at Fomana, Kumawu, and Takrady. We didn't stop it. We finished it. Correct. We came and met the Eurojet projects. Maybe that's your example. The 9 hospitals, which President Komfo initiated the funding. And throughout the 8 years, they couldn't finish. We came and finished it. There are about, 17 projects that we inherited from the previous government that we finished. Bekwai Hospital is one of them. We finished 6 of the Eurojet projects. And then even in December, we also commissioned even one of them. So it's about 2 which are not yet finished. We also came and met hospitals, which were 10 of them in Central Region, which have just been started. We finished them. There were 5 of them which have not started at all. We started it and finished it in Greater Accra. So the past Akufo-Addo government is not a government which kept that norm. So we believe that I'm coming. I'm coming. Let me conclude. Let me conclude.
Right,
maybe I'm not being very political, but I believe that health, we don't play politics of health. So if something is started, because I will repeat it here, health is the basic need of the people that you rule. It's not only basic need, but health is also it's investment. So there's nothing you put in people's health that is waste. It's not a cost. If you look at health as an investment. So that was what, as advisor to the president, that is what we put in our mind. Not that we have 2 years, he has 2 years to go. So if he doesn't finish, nobody will finish it. So I entreat whoever, the government which has come, sit down. We gave them the transition document. Everything is written there. We will come there.
We'll come to that.
So we should try and finish Agenda 111. You should go to the villages and the communities and ask the people and the chiefs and the people. Everybody is waiting for us. We are very thrilled of it.
I know there's a lot on your mind. I want to focus on that. You are not a politician. You are a bureaucrat, right? So probably the way you think might be different from the way the politicians think, right? So you were thinking rationally that this thing that we are doing for the country. It's a good thing. So the next government comes in and they will continue. That is how you made your decision. Knowing what you know now, based on what they are saying, that okay, one was completed, we need this number of billions. Would you say that maybe the decision that you made, right, you should have reconsidered that?
I want to remind you, I'm a politician as well as a technocrat. maybe a very good, one of the best politicians, because I will see the truth. I don't hide anything. If it doesn't work, I will admit it.
We know our politicians never speak the truth, but go ahead.
Yeah, but what I will say is that looking at it, I think that we took a very good decision, and we knew what we were doing. And if you are going for elections, it's not 100% that you win. It's like going for class prefect.
Okay.
It's either you win or you lose. But the most important thing is that whoever takes over from you, that is what leadership is all about. If I'm advising them, what I will say is that I will even concentrate and finish this very laudable heritage project and make sure that, because I'll give you an example. Kolebu was built about 100 years ago. We are all enjoying Kolebu, isn't it? That's why I train. That's why people go for their best, their highest treatment. Anokye was built 70 years ago. Everybody's enjoying it. So if you put a health facility, you look after it very well, you maintain it very well, our children will use it. And then remember that there were some people who were ahead who put our money where our mouth is. And I believe that if that is the thinking of any politician in this 21st century, in this digital age, we should let it go and then move forward and say that when I come and meet anything, I'll do it. And mind you, I was very happy when everybody was campaigning. The President John Dramani Mahama at various places said that when he comes, he will complete Agenda 111. Didn't you hear it?
Yeah, sure.
Yeah, so what has happened? What has changed?
All right, let's go into something. Now, you say the Agenda 111 was reactionary, right? Something that it is reactionary, does it mean that you had a sources of funding, right? You knew that this is the amount of money that you have, right? You have conceptualized this thing, which is a reactionary to something. Did you have the funding sources? I'm not talking about an afterthought. I'm talking about after the time that the president said you were going to construct 88 hospitals. You knew the sources of funding because we had a situation whereby some years back we were talking about SSS. The question came up as how you were going to fund it, right? So as at the time that the concept came up, did you know the sources of funding right at the origination, not afterthought? Did you have the sources of funding?
Yes, you need a source of funding.
Okay.
As I said, the planning for Agenda 111 was over 1 year. I'll give you a very short in brief. You see, Agenda 111 is divided into two. One is the district and the two zonal psychiatric hospitals.
Right.
You know, we are putting all the psychiatric hospitals in this country at the coastal zone. Correct. People who are training in psychiatry affiliation, or they have to move to Pantai or Komfo or Accra Psychiatric Hospital. And then we have the regional hospitals because we wanted to also let the new regions have their secondary referral centers. Already there were, Ministry of Health has some projects that they were doing, Takoradi one, which we wanted to also have Takoradi have a befitting and the field container will be refurbished. And then OT1. So 5 of the regional hospitals, the Accra Psychiatric Hospital, were supposed to be external funding, what you call engineering, procurement, and construction plus financing, like a turnkey project.
What you are saying was within the COVID time.
Yes.
Okay.
Yes. Right. That's why we decided that those ones are a bit 160-bed hospital, a lot of equipment will come in. So it's the price, it will be a bit, the price is around, if you look at the 5, it's approximately about $100 million or so. So we said we'll look for funding. We have gone through the processes. The people were interested to bring in the funding and build it and do a turnkey project for us. But because of debt restructuring, they've done value for money. It's waiting at Ministry of Finance when that one is over. So we haven't started that one. Then we decided that it's not every time that you go out looking for loans. Correct. Because if you look for external funding for hospital, there are similar hospitals which were built of about double the price of Agenda 111 hospital. So when they price Agenda 111, as the president said the last time, averagely the cost is about 17 million per one hospital, plus equipment. Right. Plus equipment. There are 2 types. There's the smaller community districts have 60 beds, which can be expanded to 100 beds. And then the bigger communities, municipalities have 100 beds, which can be expanded to about 120, 150 beds. Right. And everything costs. The 60 beds are slightly cheaper because of the construction cost. So, but it's averagely about 17 million, 16.8, 16.9. So if you add all together, it's about $1.7 billion for the district and the 2 zonal psychiatric hospitals. And then, so far, then we said that, look, there is what you call a heritage fund, a heritage project. You know, right. The main source of funding, I've heard people saying that there was no source of funding. There is. We have oil, we drill oil here, we sell oil, there's taxes on oil. The money, some of the money are used by this Assembly Common Fund and all these things. So we said that the CAPEX, that's the above budget formula allocation, CAPEX, 20% of it will be earmarked for Agenda 111. And even we also wanted to increase that one, we're negotiating to increase it to the Minister of Finance, and the Sun has a limit that it can even go to 25%.
Hold on.
So I'm coming.
No, let me read something that you sent to me.
Yeah.
Then I'll question you. Right. Say, for the district and the zonal psychiatric hospitals, there are two sources of funding, which is the district, the direct government budgetary allocation, then oil revenue. Now, let's try to, we are trying to situate our conversation within a particular context. We're talking about COVID time, right? That district hospitals, district assemblies were not collecting enough revenue, right? Then oil, right? We knew we had challenges also. And the point is that is oil even a reliable source of funding, given that the prices fluctuate almost all the time? These sources of funding are not very reliable, right? Because we are talking about COVID, districts, things have been shut down, right? So district things were not working. And oil revenue is not reliable. How can this be what? Critical, reliable sources of funding for such a project?
Well, but the oil funding will continue coming throughout. It's not only COVID period.
Because of the
the COVID period, we started, and then we also use about $100 million from the COVID fund. That's what we used to initiate it. So initially, we had $100 million from COVID fund, and then we were relying on ABFA from the COVID, oil revenue.
Correct.
You see, oil revenue will continue coming. We can even, there are things that we are doing, if God have permitted and Ghanaians have voted for us to come. We knew where, from even the oil revenue, what we are going to use the oil revenue for, to get money.
My point is, oil revenue is going to come, but there will be fluctuations in oil prices. Maybe at one point when you are making your budgetary allocation, it's $100 a barrel. At another time, it is $50 a barrel. So how do you offset that differences?
I can tell you, it's not a reliable source of funding. Tell you, by the grace of God, during that period, this analogy didn't happen. He even had more money than what was supposed to be for that, for example, 2022 and 2023. So if you look at it, if you go to Dubai, what you see in Dubai there is the taxes that they got from oil revenue. That's why they use it to do all those fanciful things that people are now going there and then paying money. So to me, even if you put about 50% of whatever we get from oil revenue into health, maybe I'm being biased because I'm a health professional.
Sure.
Because health is wealth. And there's wealth in health. So if anybody says that there is no source of funding, there is source of funding. It is in our handing over notes. We discussed at the transition. We can use that based on the oil funding and then go to even our local banks to do a consortium.
This is my worry. If that is your sources of funding, it does not mean that when there's a change of government, the other government is going to use your sources of funding. Would you agree to that?
Yeah, but they shouldn't say that we didn't leave any source of funding. It's not true. That's what I'm trying to tell you.
Okay.
It's a fallacy. It's a fallacy. And I will collect it any time that they say it. There is. It's a way that we use that type of, if you don't want to use our system and you want to use another system, so be it. But to me, if anybody consults me, that is what I will tell the person, that use this. And to me, is the most important thing, because see, some of the money goes to this assembly for common fund and all this. And then once also our revenue starts moving up, and I was so happy with the finance committee, select committee on health at Parliament. They were always interested because you see, most people, most constituencies have Agenda 111. Everybody wants the one in his or her place to be done, and done quickly and done very well. People are saying that, why didn't you start a few? We could have used it. You see, that to me is, so, excuse me for my words, that if you say that, you are simplifying this over simplification. Because which place should you start first and which place should you lose? You see, as a leader, and I've been in leadership position for a long time, I take very bold decisions. You have to bring out bold initiatives, not do things as they are supposed to be. If you're a leader and then, or a manager, you are going to do things as it is, like, oh, that's how we do it, you will not get anywhere.
Yeah, but how do you reconcile bold initiatives when it is reactionary? When the decision itself is reactionary?
I told you that I use the word reactionary because we are reacting to a situation, not as the definition that you want us to go in.
Okay, now let me ask
because
you a question.
Because you see, you were trying to have an analogy that reactionary means knee-jerk. Yeah, it's not a knee-jerk. That's what I said, that I beg to differ from what you were saying.
Okay,
I'm using the word, I would say it's a reaction to what we saw during COVID period.
Correct.
But if you use a reactionary like that, it means that we didn't think through. But I've told you that we used 1 year to think through the whole of 2020, the whole of 2022, 20 to 2021, July, before we came to a conclusion that let's move on.
All right. So
and
now,
then 2022, God being good, so good, the COVID even then minimized, and then we declare it that it's over.
All right. We'll come to our participants if they have questions.
We thought of it. It's well thought of. We've given the new government all what we're doing. It's a new government. They can do what they think that they can do. I've heard that they want to do this and this. I wish them well. But we will be watching and looking. And anything that maybe, if you come and see an initiative, a very good initiative, a very good heritage project, a very good legacy for the good people of this country, and then you want to talk about it as if, oh, they didn't think about it. It is not this.
I don't want us to go into the politics, but for our participants, if they have any questions, feel free to ask your question. But let me come to you again. Let's look at the free SHS as an example, right? It's a policy. It's not backed by law. Government was doing what it's supposed to do. But when the government, at the very last hour, the government was trying to have it backed by law, right? So that
government was trying to do what? No, I didn't hear that well. The government was trying to do what?
The majority, the majority wanted to take it to Parliament to have it backed by law.
Yes.
Correct. Why didn't you do the same with the Agenda 111 to go back to Parliament to get Parliament to make it the law so that you will get the funding, a reliable funding?
But I don't see an infrastructure development that we are doing for the good people of this country if you go and back it by law. Anyway, maybe I'm not a lawyer.
Okay.
Maybe or second thought, that's why we will have done for the good people of this country. But you see, as I said, leadership. You look at things that is happening. Look, let me tell you something. There have been the election in Germany only last week or last 2 weeks.
Sure.
Have you heard anything? They are continuing.
You know, that's what I'm saying. You have to understand. African politics is different from European
politics. Yes, we respect the politics.
Become a problem.
But should we continue that type of politics in this country like we have been doing over the years? No. If that's the type of politics we want to do, then I beg to differ that maybe we have to go back and do something else. Go to maybe some other way that you can get things done in this country. If you do that, we'll continue to be where we are. It will be like Agbaja. You dance forward for 3 steps and they come back 4 steps.
Yeah, but that is what, that's what we've been doing. All right, let me go to Dr. Thomas Adekum. He has a question for you. Right? Doc, go ahead.
Yes, sir. Good evening, and good evening to our participants. I get the impression that when the president mentioned knee-jerk approach, I get the impression that he's not being, to be a bit economical with the truth, he's not being factual. As a student of public policy, I get the impression that what the previous government has done was to respond to the needs of the various districts. So in public policy, I think it's fair for us to classify that as a problem-based decision-making process, which is emanating purely from the inefficiencies in our healthcare system at the point of COVID. So that was a quick clarification to put out that I may not entirely, I'm not sure reactionary will be the right word to use, as Dr. Nsiah has said, but I get the impression that this was a problem-based approach that the former president has put up. Thank you.
All right. So somebody.
Yeah, thank you very much, Prof. I've removed my word reacting to a situation. It's to be a problem-based approach.
I'll come to David later, but let me try to clarify something, right? If you are a bureaucrat or you are just an intellectual, right? The words that you use may be different from the words that the politician is using. So over here, we are using the word consideration, but the politician is not going to use the word consideration, or the politician is going to use the word knee-jerk reaction just to make the other person look bad. So we should be able to come to terms with the way we do our things, right? The politician will use the word knee-jerk reaction, but maybe we intellectuals will use the word reaction. Okay, let's go to Dr. Frank Sebo. Yeah, go ahead, Dr. Frank Sebo.
Thank you very much. I just wanted to find out from Dr. Nsiah, how many of the facilities are close to completion or he would classify as having been completed? I'm very much interested because I think that we need to know so that if we need to push for operationalization of some of these facilities, we will know which ones to focus on.
All right, Dr. Nsiah, even though you've sent to me, I want you to make that clarification yourself because the president, no, I don't want us to get into the politics. The president is saying one, what, Vosukwachi and Boama are also saying things. So that's what I'm saying, that this sort of data becomes a problem because they try to create some of these data to suit their own narratives. Right. So let's see, Dr. Nsiah, if you can help us based on what you sent to me. How many, in your own estimation, that you have done, not what the government is saying? Government will also present things in a different way, like I said, right? So how many do you think have been done from that perspective, right?
Yeah, thank you very much. So far we've started 101 of the 104 plus 2 psychiatric sites, or 101 plus the 2 psychiatric sites. So we are now doing 99 district hospitals and 2 psychiatric hospitals where contractors are there and they are at various levels of progress. As at 31st of December, out of the 101 sites, 3 of them were commissioned on December 5th by His Excellency the President. And they are Atwumakwa in Atwumakwa Angoma municipality in Ashanti region, Oforikrum in Kokobe in Oforikrum municipality in Ashanti region, and Bokro in Ahanta West municipality in Western region. Okay. I've heard people saying that there are no even chairs and beds there.
Furniture.
The media were there and everything, and we have hospital beds. All the equipment are ready. In fact, 70% of these 101 hospitals are above the 37 of the size of the 101 active sites are above 70% progress completion. If you remove the 3 from it, it means there's about 34 of them, which if these hospitals are about 70% completion, it means the roofing has been done. Some of them have been tiled. The floors are being tiled. They are doing external works and doing other things. And then about 28 of the sites are between 50 and 70%, and the 36 of the sites, because of land acquisition, some of them started very late, that they are also going on. So, Dr. Serebo, if we need to operationalize, you see, people have been telling, oh, there's none of them working. Yes, there is. If you want to operationalize a hospital after it's been built, equipment has been installed. They test the equipment, they train the people that are going to work there on the equipment, and then they start working in the equipment. The 3 that we commission, if it's somebody's private hospital, by now you'll be running outpatient department, and maybe the small touches that they are doing in the theater, when they finish, then they can start using the theater. The hospital beds are all there. All the equipment, the suppliers are ready. At any time, any of these hospitals are ready, they will send the equipment. Because equipment supply for the first ones, which are about 70%, have been signed. It was done somewhere in September. And then the second part of it also have been done, because equipment has a lead time. X-rays are not manufactured and sitting on the shelves. So we have to do it early enough, because when we're trying to commission, we have to force ourselves for them to do emergency delivery to us. But now they are stocking their warehouses, and then whenever we are ready, we call them, give them about 2 weeks notice, they'll come and fix the equipment. So for the meantime, Dr. Serebo, I know you are very much interested. Ghana Health Service and the Ministry of Health should get people to be ready to go to Trede, Kokobin, and also Bokro in Ahanta West, so that they can start training, testing and training of the equipment, and they can start using it. The same thing. Okay. So we need, as a country, to give some of the nurses and doctors and biomedical engineers and biomedical scientists who have not been employed, who are at home. There are a lot of them. Government, in this budget, we are going to have a look at it to see if they are going to also allow financial clearance to be given to these people, as we sent to the Ministry of Finance, so that all the hospitals, including the VAMED projects, 5 of them in Ashanti region, 5 of them in the Eastern region, which have been commissioned, which have not been operationalized, because these hospitals were commissioned the first week in December before the president left. So the new government took over in January. So instead of maybe all this talk, but now they should also having plans to go and put people in to go and work. So pressurization is not that when you finish the hospital, we have to move people in to go and work. And that is the onus lies on the ruling government or the government to get financial clearance for them so that our numerous youth health professionals and other people who are at home will get jobs to do. And that is one of the issues that I want us to discuss here.
I'll come to David. I just want to make a quick comment, right? So the problem that we have is that the political actors make decisions, bold initiative decisions, right, in terms of what you want to do. But at the end of the day, you don't get whatever you want to do done. In terms of 70, they keep using 70% competition state, this state, and this state. But at the end of the day, it is we, the citizens, whose taxes have been put into these projects that are not completed, and we have been to be the losers. Because if the government does not, because you are trying to look at a government, the political actors to be rational, that they will do what is right. But we know political actors do not do what is right. So maybe we have to move away from political actors acting in the interest of the people. Because 70%, because we know what happened during the previous government when they constructed all these e-blocks in villages and things like that. And they said some of them were not completed. So this is what we find ourselves. It's like a back and forth and back and forth and back and forth. If the government does not go ahead to complete this project, it becomes our debt. All right, so let's go to you, David. David, let's hear from, what's your question to Dr. Nsiah?
Yes, that's the reason why I'm telling you that. You see, for Agenda 111, I'll say it again here that was well thought of. We knew all these things. We knew that if you are not very careful, you finish the hospital to be sitting in the bush. Nobody wants to go there and work. To extend that, we even thought about even the accommodation, especially in the rural districts, were too few for people to move in there. Because I told the president once, when we went to OU, that here, if you don't have a medical village or a place that the workers will stay and be comfortable, even if we send a bishop or a chief malam here, you won't come.
Okay.
So that was another plan that we're doing. And we're going to do it with the private sector. People were interested to come and put proper accommodation flats with commercial area, entertainment centers, even a nursery, and even have a place where the teachers will be. So you know within the four corners where your people are. And all these rural communities gave us land, about 10 acres. That's the plan that we did, which we're finalizing it. The people went to Ministry of Western Housing. You can ask Honorable Kojo Nkrumah. He bought into it straight away that we have to do it. So we plan it. But my point is that I'm pleading with everybody, especially with my fellow politicians. I told you I'm a politician too. I'm a technocrat and politician. So when I'm saying something, I know what I'm supposed to do.
You're a politician, but you think that your other politicians are rational actors. They will act rationally.
Yes, you have to. That's why advisors are there to be advising and telling them that we don't put this in there and leave it. We need human beings to work in. That's what we have to do. So please, I'm saying that if you just want to just discuss Agenda 111 was wasteful, you didn't think about it, and it isn't, I beg to differ. That one, none of us who have worked over the period of time in a leadership position and will know what health is, will agree. I will agree. Okay. Because if you do that, it's an insult to my integrity and everything. Because we didn't do that. We were solving a problem.
Okay.
Yes.
All right, David, go ahead. Ask your question.
Yes, Dr. Benjamin Akwe, thank you very much. This is just a quick one. It's just a follow-up on the Dr. Jekum. Was it Dr. Jekum who spoke earlier?
Yeah, Jekum Chairman, yeah.
Yes, I just wanted us to settle this terminology of reactionary and knee-jerk and what have you. And I wanted to just probably pull it off from the policy theater or framework, and then just bring it down for all of us to, I just wanted to just make it very simple for all of us to get it. You see, normally when there's any shock, okay, in the economy or in the system, okay, there must be a response. And I want to use the word response, okay, not just to stabilize it, but to also address any potential shock that may happen in the future. And particularly for you, Dr. Benjamin, I'm speaking to you particularly. And I'm asking this question so that when you answer it, it will address the concerns of all the people on the platform. Now, what happened after September 11th? September 11, when the September 11 attack occurred in the United States, what happened?
Right. Yeah, there were certain steps, right? We know the Patriot Act was passed, so many things were done.
Good.
But don't forget,
prior to September 11 attack, there were certain things that were not in place.
Correct.
But that shock, okay, prompted the United States, okay, to enact the Homeland Security Act 2002 and to set up the Department of Homeland Security, which was not in existence, and also to pass the USA Patriot Act.
Correct.
And the purpose was to help help detect and prosecute terrorism and other crimes. Correct. And that is what has helped protect the United States up to date. So it was a response to that shock. And so similarly, what happened was that the COVID pandemic was a shock, not just to Ghana, but it was a global shock. So the response of the 111 was to make sure that it was not just to address that pandemic, which was very, very national in character, but to prepare it so that in future, any other pandemic that will occur, the country will be in a position to be able to address it. So it was a response. And so anybody who says that it was a knee-jerk reaction probably may not be looking at it from the right lens.
Okay.
Thank you.
Let me say something briefly, right? I understand the way you are trying to make an analogy, right? You are looking at things from a Western perspective, right? The way you started, looking at the US, right? Your analysis is coming from a rational Western perspective that this is what should be done. Let me ask you a question. Do you think what is happening in Somalia, where they are killing themselves over here, will be happening in the United States?
I'm a little bit hesitant.
Yeah, you know why I'm making that argument? African politics and African governance is different from Western, different from the way we see things in the West, right? Things that will never happen in the West, you see it in Africa and you'll be like, are these people thinking? Right? So that is why I don't like that analogy, right? Why things happening on the African continent, and you ask yourself, what are these people thinking? So we should know that our leaders are not rational.
You are right, except that, Doc, what is happening now in the West, the devolution of the politics in the West, I'm afraid is getting even closer or even worse than what is happening in Africa. But that is a discussion we can have later.
Correct. No, but like I said, I do understand that. Don't forget that. Fine. What we're trying to address. There's a problem we are trying to address.
Yes.
First of all, we have to look at the capacity, the capability, because we are having financial challenges.
Yes.
Right. So yeah, but go ahead. If there's somebody else, we can go to somebody
else.
The
real point I wanted to make is that the argument that we just want to, I want us to just have some finality to the fact that
absolutely
the idea, the conceptualization of the Agenda 111 should not be seen as a knee-jerk, but that it was a response appropriately, okay, to address a shock, okay, of the pandemic.
You are right, because
now the discussion of whether
hold on. Dr. Chairman, yes, said epidemic preparedness, ambulance services, laboratory services. So these are all responses, right?
Exactly. But as to whether we now have the money enough to be able to carry through is another discussion.
Absolutely.
is another discussion. That one is another discussion. Thank you.
So now the government is saying that what have been done so far, they need $1.7 billion to complete it, and they don't know where the money is going to come from. So that means going forward, what is going to happen to something that is in the interest of the people, but for whatever reason, for political expediency, right? It might not, because don't forget the current president also come up with his own health policy, which is yesterday I heard him saying what the Mahama Care. So they also have their own policy that they want to implement. So if we are not very careful, all these things that has been started, right, may take a setback while they come to do what they want to do, because they are always thinking about the next election, things that they have to do to win the next election. Yeah, but anyway, if anybody has any other questions.
But let me correct you about even that we need 1.7 billion. It's not true. That's also a fallacy.
That's what it says.
Yeah, it's not true. Because we gave them the handing over notes. What we gave them as at the end of October 2024, when we were preparing the handing over notes, because we have to prepare handing over notes, either we win or they win, was 1.4 billion. So I don't know where you got the 1.7 billion from. The 1.7 billion is for the total cost of the district and then the psychiatric hospital. Even as at the end of December 31st, December 2024, it is now it's $1.377 billion. So that should be corrected. I don't know where you got it from. Because if you remember, I'm coming. If you remember, they themselves even quoted it that they need 1.4. So all of a sudden, why should the whole head of state say that it's 1.7? So we don't know where the 400 billion or $300 million is coming from. It's just trying to give that, oh, we don't have money to do it. So if you're going to do Mahama Care about chronic diseases or chronic renal failure, and you forget about Agenda 111, we are praying that nothing comes into this country again. But once we are in this world, once the globe is one big village, if we are not very careful and there's another pandemic, then we start rushing. That's where your knee-jerk definition will come in. We don't want that anymore. We have to sustain this response, as Dr. Benakwe said. So please, I think all of us have to put our word in and tell them that, look, wherever you get this money from, they've shown you where you can get the money from. So look at the oil revenue, use the oil revenue as maybe something to go and look for money. You can get it, because I know what we were doing around August before we left. They wanted the elections to be over, and then we sit down again. So we are there. We can give them free consultants.
Let me speak on the numbers. Like I said, I have engaged politicians and they throw numbers. So I don't engage politicians when they come to numbers and statistics and data, right? They say whatever they want to say. But going forward, they come with their own projects, things that they want to do. They want to pursue it, right? If you, Dr. Nsiah, you have the opportunity to meet the president, how can you convince him, since he has his own project and he is looking at the next election about the thing that he has to do for his next candidate to win? How are you going to convince him that do not neglect this project? This project is too critical for the country and we cannot. How do you do that, since that has been what we've been doing for ages? That's the problem.
It's not only me who should even convince him. The chief, a chief at Yoyo, you should go and meet the chief at Yoyo. He will tell him why he needs this project. You carry pregnant women from Yoyo to Naregu, it's about 75 or 80 kilometers. They die on the way, they have to send them back for burial. Or they take to the hospital for them to remove the baby, because they don't bury dead baby with a dead woman. That is the point. It is not this sincere care. You see, so when it reaches time that you think that we have to prioritize, you prioritize properly. So if he calls me, I'll sit him down and tell him that what happened in 2020 about the COVID. You shouldn't think that Ghana cannot be, we are over. It's not yet. It's not over until it is over. There are a lot of diseases which are coming in and out. And within a matter of 12 hours or 10 hours, somebody from China will be in Ghana. somebody from anywhere will be in Ghana. So don't let us be caught again pants down. That's the reason why we want to do this. Let's strengthen our health systems. Once you strengthen your health system, then others can be added on. Because if you are not healthy, you cannot work. So I will try and convince him that this is where what we're using. Let's look at how much you get per distance every time. Let us approach these people. They are prepared to underwrite it and then use it that, oh, since it will be coming regularly. Because since it will be coming regularly, bankers want to use their money, isn't it? Yes, they want to invest.
Okay,
then they can invest into it.
I don't know how Dr. Frank Shribo of the GM, I don't know how they will play a key role, but let me chip in this thing. We have not actually used the diaspora very, very well in terms of raising money to support some of these programs. Let me give you a good example. In Ethiopia, when Ethiopia was trying to do the Grand Renaissance Dam, right? What they did was they sold bonds to Ethiopians who were overseas, and they were able to raise money, right? Shouldn't the government start thinking in that light, that this is a good initiative? Let's see how we are going to get the diaspora involved by dishing out bonds, and the money will be used to do that. Okay, let's go to David. They will come to later to Dr. Shribo. Yeah, go ahead, David.
Yes, thank you very much, Dr. Benjamin Akwe. I have just a quick one for Dr. Nsiah. Dr. Nsiah, this is just a quick follow-up. I think the Agenda 111 for me is laudable because one, it aims at stemming the addressing the problem, but also to potentially address any future pandemic that was going to come up. But the question I have for you now is, in planning, has to do with planning. Now, couldn't they have, because of our peculiar, it's not for just Ghana, but especially for developing country economies like Ghana. Now, because of the peculiar nature of our finances, couldn't the government have come out to say, let's say we have this, we are going to put up 111, we intend to put up 101 in all the districts. These are the plans for all the districts. Okay, but we are going to start with, let's say, 10 because we have the monies for it and complete it. So we have showcased all that these are the places we are going to build in all the 10 districts, and we have the plans, but we are going to start building, okay, 10. When we finish the 10, we raise the money, build another 10, so that any subsequent government that comes up, if you're not able to finish it, can come and take up those plans, okay, and pick it up from there. Instead of spreading the money thinly, where you have some at different levels of completion, some at foundational level. And I think that with that, we could have gotten maybe probably about 50 of them now being operated. I'm saying not completed.
Okay, David, let me buttress your points, right? When you listened to the president's speech yesterday, he said $400 million have been dispersed. But if they probably have focused on probably like a few, they could have used the $400 million to construct 22 Agenda 111 projects. So what you are saying, I'm trying to buttress what President Mahama said in the State of the Nation address. He said, instead of having this huge project, it's a laudable idea, but the $400 million that has been dispersed so far would have constructed 22 of those hospitals. So yeah, Dr. Asare, I'm just trying to.
Yeah, you see that I'm smiling. You see, Agenda 111. We have argued about this thing over and over before, but what is happening now? The prioritization is already there. You know the way the project is. The contractor work. You give them mobilization. They work. Some of them are faster than the others. There are some people who are taking only about 3 interim payment certificates, very small. There are people who have taken about 7, 8. So those who have taken 7 and 8, it's like a race. They've taken the lead. So already, that's why I said that about 37 of them have taken out as people potentially, if it's 70% and above, that they can finish within about 2-3 months or 4 months, maximum about 6 months they will finish. So once you bring the certificate and it's passed, you are paid, not the person who is not working. You understand what I'm saying?
Yeah.
If you have done what you are, what Dr. Akwe is brilliantly exposing, I'm sure by now they would have come and said that they've cancelled all the rest. They will cancel all the rest. But now, either we like it or not, there are sites which are not maybe moving so fast. But when they see, contractors are also very funny people. And you see, they know what they are doing. When they see that certificates are being paid to others, a lot of them also go to site and start working and finishing. There are some of them, the ones that we commissioned, they have some small works to do, but they have some money to collect, but they want to finish and collect their money later on and go away. So that's how it is. And then one thing we should know is that nobody looks if we have not even used the money, because we use our certificates that we have to go to finance. I was always going to finance to go and fight for more money. Because if you don't have certificates, why do they give you money? Because sharing the government budgetary allocation, they were doing it in thoughts, based on thoughts for people. But if they know that, oh, let's consider General because they have about 4 or 5, 10 certificates waiting, which is the amount of this, and then they give it to you. If you don't use the money, it goes back to chest.
Sure. Okay.
So that's how we are using it. So that is, if people don't understand it, that's how it is.
Dr. Frank Sribo, you've been at the GMA, right? President
Yes.
Mahama has made some proposal, right, so far in terms of allowing some of the Catholic hospitals to take over some of these things. What is your take on that, and how can GMA play a key role? Because you don't want to see some of these projects become white elephants, right? What do you think about the president's proposal so far?
I think that even as at last year, before the elections, we had already engaged the government on these Agenda 111 projects, and we had proposed that if it is feasible, some of them should be taken up as private enterprises, so that those people will run the facility and even be able to pay back government, so that government can even use that money to even build more hospitals and facilities, instead of the government actually controlling all of it. And I think they're paying salaries, maintenance, and so forth. And basically, there is nothing like a revolving fund or anything like that. So we had actually written that already to both sides. In fact, in their manifestos, it was something that we wrote to both sides. That is something we wanted to see. Currently, as we speak, all these pension funds, the worker pension funds, I'm sure you remember that recently, in terms of what we call treasury bill, has been rejected. A lot of them have money. They wanted to buy treasury bills. They are not getting treasury bills to buy. I am happy with that because it was unsustainable. The percentages were outrageous. But there is potential for some of these pension funds to take at least a larger chunk of these Agenda 111 projects and sunk in their resources. Because look, a lot of them, they don't need the money now. They have a young population that is working, and so they have time. And once they sunk in their money, it is possible that they will get returns in the near future, which is not going to take too long. So there is money that I believe we can source from all of these areas and ensure that we complete these projects. So it is those are the areas that we think.
Are you suggesting like a century-like forum seminar on Agenda 111?
It will be perfect, because at least it will give us all of us an opportunity to be able to go in there and tell them exactly what we think. Look, sometimes when you hear people talk about the fact that the FAC facilities or the Catholic facilities and the Christian facilities are run better than Ghana Health Service, it's actually not factual. It is because even their tariffs are different from the tariffs that are paid to the government-run facilities by some of us. It doesn't mean that we are bad managers, but because people don't give you your resources to be able to run. If you are given the same platform, the same freedom, such that you don't have people overlooking, writing all sorts of letters to you, pay this person, do this, send this money to this workshop, go and do this, and you can't send those directives to CHAG. So those directives comes to us. And so if we are given a free hand to operate, I can tell you, 99% of the Ghana health service facilities will generate more money and make profits. So it's just a matter of looking at what we have to do and then be able to ensure that at least we complete these projects. Because I am very, very much interested. And I think that whether we like it or not, it's been started. We need to finish them. We don't have to leave them in the bushes and leave them to rot. Some of the machines and so forth that are already in the hospitals, if we leave them within a short period, we will go there, we'll realize that all of them are out of commission.
Right.
So
maybe Ben, let me come in here.
Sure.
You see, talking to Chuck to complete some of the hospitals and use, it's like going to somebody to look for cloth to go to funeral. The person that you are going to doesn't have the cloth. Because Chuck, if government is not paying the staff, they cannot even perform very well, as Dr. Srebo is saying. Government pays all the salaries. But that's why I said that government should sit down. There is money within the country, and he has mentioned the pension fund.
Yeah, absolutely.
So why don't you do that? And they say that this, and they start to maybe stop all the noise that we are doing. There are two types of things. You see, first, getting somebody to put in the money and maybe the private sector. If you say public partnership, I don't have a problem. For the private sector, like pension funds, you use pension funds. When you finish, you bring in private people to come and manage the hospital. So there are two different types. Getting people who may be pushing more money in addition to whatever money that you are getting for this, so that they work over a period of time, make their money and pay off and give it back to government or continue running it. That's what they use pension funds in, for example, South Africa to do. They are in hospitals in Kenya. They came to us. In fact, so one of the people who want to come and put up one of the Agenda 111 is going to use pension funds of the South African pension funds. Why can't you use the same pension fund from Ghana? There are billions of Ghana cedis sitting there, which is billions of dollars. Two, if, for example, you finish the hospital and then you want maybe charge for one reason or the other to ransom, as Dr. Srebo said, the management-wise, if you want even Ghana Health Service to run it, I believe that you train people to manage the hospitals. Or why don't you call, for those in the rural areas like you and this thing, you can call a group of young and enterprising doctors, say that you form a company, go and run that hospital. And they go there, they do both clinical work and also the immunization and everything. So it's comprehensive healthcare system in the district. Within a matter of years, they won't even come back to Accra. And they will go there with nurses and the rest. So I believe that they should differentiate between the two, that the private sector managing it when maybe it's finished. And two, sourcing fund, and I'm happy that Dr. Srebo is saying it here, that he has even now brought to mind that we should have even engaged long time the private the pension fund. And SNIT puts their money into things which are not very productive. But hospital, you make money because they can even move into medical tourism in some of these. I've always been saying that I want to see medical tourist center at Pasa, at Paga, at Adabokrum, so that they can attract people from the neighboring countries. So Dr. Say, well, I think that's the way to go. If they call us, we can go and sit in and then discuss it and give them our experience of managing hospitals even within CHAG system and within the government system. So you shouldn't jump
thank you very
that they
much.
can build hospitals.
Let me come to Dr. Tim, right, who is an expert on security. Dr. Tim, what are the security implications of all this conversation that we are having, knowing very well the effect of Galamsey? We've not yet seen the effect of Galamsey yet. How does the effect of Galamsey complicate the situation and pose a national security threat to the country? Doc, can you hear me?
Is it me?
No, Dr. Tim. He's a
Tim, okay.
expert. Correct.
Okay, all right.
If he's not hearing us, if we can get.
Look, I'm in traffic, and somehow, what do you call it? I didn't know you were addressing me. I mean, when you repeated, that's when I heard. Okay, what is the question exactly?
My question is, the discussion that we are having, right? We've not factored into the unforeseen diseases that are going to arise as a result of Galamsey. Because we are seeing some signs that Galamsey is also coming up with its own diseases. So what I want to understand is that how does Galamsey now come to complicate whatever we are already dealing with, and how does that pose a security threat to the country?
Yeah, thank you very much, and then good evening to everybody. The issue of Galamsey certainly is just as COVID was an existential threat. If we downplay the effects of Galamsey, it will also become an existential threat to us. The first thing is that everybody needs water to drink. Our plants need water to drink. We need water to drink. Our animals need water to drink. And then water that we can really see is safe. Galamsey is the biggest threat to our potable water today. And whether both surface water and even the underground water. So in actual fact, we're moving towards having Galamsey as an existential threat, something that would affect our prospects as far as our survival on this, what do you call it, the globe is concerned. And I believe that anything that we need to do to really reverse the trend, the dangerous trend we have in that domain needs to be done. The provision of the excellent 111 hospitals, it will come to naught if we don't have healthy people to go to school to become nurses and become doctors to have them really operationalized. Even when they are operationalized, the water they do have to use for patients. If all that is under threat, then it becomes a problem. We cannot import water to run our laboratories. It's certainly feasible for you to say you can do that if you have the money, but it's almost not practicable. And for the problem about Galamsey, it's just simple. It's we as a people who have decided to stay with it. It's not just the political class. No, it is all of us in the caught in it. If people are really committed to fighting it, we can have it. Stopped in less than 3 months. Because if everybody looks to a small political class for a solution, unfortunately, they are always at their wits' end when it comes to some of these things. Because the willpower to bite the bullet is very, very often lacking. They would have all sorts of the vocabulary to defend themselves, and then that's why we blame them. Because if they are humble enough to accept that they have limitations, we will sympathize with them. But they don't create the impression that they are human and they also have a limitation. Mm-hmm. Yeah. So in coming at them, people really do not hold back because they give us the impression that they are so mighty. We have had, there's a new government now, LDC yet, but is there any proper new direction in the fight of Galamsey? No, in a big no at that too. So as I mentioned, LDC yet, the only variant we are having is that we're going to have inclusion of chiefs in the fight and the like. Let's see in concrete terms the commitment that the chief executives will not come in between those polluting the water and then calling them, and then the law enforcement agencies that go to stop them. Let's see concrete, measures that will really make sure the Odikro and all other opinion leaders in the villages are empowered to protect their water. Then alone can we say that the political class is leading by their word. But if not, it's you always take their word. We have seen it all. You always take the word that what they say as far as Galamsey is concerned with a pinch of salt, because they think more about their votes, unfortunately, than what we are about to lose, which is the lifeline to our health.
All right.
Thank you.
Thank you. Yeah, Dr. Frank Sribo. So going forward, how do we crowd out the political narratives, the narratives coming from the politicians? Because the president says this, then the opposition or Dr. Nsiah come out to say something else. Then this is, so it's like a back and forth and back and forth and back and forth. How does independent voices like you or the GNA crowd out those narratives, those political narratives, so that we'll be able to come to a conclusion that this is the direction that we need to go? We don't need to bring politics into all these things. How do we do that? How do we go forward from here?
Well, I think it's always going to be a very difficult venture, but we need to try. I am sure you were around when Galamsey, as he was saying, was virtually politicized.
Yeah.
And it became a huge political issue before the elections, to the extent that those of us who thought that we needed to get the buy-in of everybody to ensure that if we have to have a sustainable fight, it shouldn't be because one party who is in power or the other who is in opposition is saying A or B, but all of us as a people should come together to deal with it. We are branded. So I am happy to hear that now, at least, we are coming to realization that it's not about politics. It's about all of us, that we should be able to deal with some of these issues, especially with this Galamsey and so forth. So for me, it's a conversation that we need to have. Even with these Agenda 111 projects, it's a conversation that we need to have. We need to be clear. We need to let everybody know that this has got nothing to do with politics. It's got everything to do with us as a country. And indeed, even today, I did mention to one of our ministers, current ministers, that look, for me, I'm interested in the Agenda 111 because the money belongs to Ghanaians. And it's Ghanaians' money that has been sunk in it. And that we have to find a way to make sure that we complete them and operationalize them. So it should be a project. Once we take up that project, not GMA alone, GRNMA, GMA, and all the other, should I say, non-governmental organizations, and then the unions, we should be able to be bold and call it out and say it as it is. And then let's see how we move. But bottom line is that it's a lot of work. It also requires some degree of commitment from all of us. And so I think it's something we need to do, whether we like it or not. That is our cross, and we will have to bear it.
All right. All right. Dr. Nsiah, sorry, time is fast spent. Thank you for everything, but you are the final word. Let's hear from you. Finally, going forward, the president is saying that this time when there's a century on health, you shouldn't boycott it. So going forward, what is going to be your final thoughts?
Yeah, going forward, I just want to say that we shouldn't politicize everything. Secondly, governance is continuum. When you come, whatever is being done, just sit down during the transition, you talk about it, you can do your politics there, argue about it, and then move forward. And winner takes all is one of the issues. Because I'm very sure if there's even a century, some of us will not even be invited. But we started it. He who started it knows why he started it and why he is doing this. So we should be able to sit down around the table and discuss it passionately without any politics.
Right.
As you rightly said, I'm a technocrat. So when I'm doing anything, especially about health, I know what I'm talking about and I discuss it without any politics. But if things are not factual, we have to correct it because we come and meet something which is very good and very, very innovative. Don't destroy it. Just say that, oh, because you can even say, to me, if you say the truth in politics, people think that if you do that, you may not win any vote. It's not true. If you accept that what this one did, it's very, very good. But I'll try and come and do it so that we do it better or we just sustain it and let it work for everybody. Everybody will respect you. You take Ghanaians for granted. You take the electorate for granted. But I believe that they also think and they also know what is good for them.
Okay.
So I believe that we'll carry this conversation forward. I'm happy that I thought the GRNA will also be on it, but I haven't seen them on it.
Okay.
That they should even sit down with us. If they like, the unions should come together, come and sit down with us because people have gotten a lot of misunderstanding and misconception about Agenda 111 so that we'll take them through and explain to them. I'm sure you've seen some of the videos that we have sent to you.
Yeah, absolutely.
The amount of work is going on. So even with the 400 million that people think that we have thrown it into the gutter, it's not true. If you see the amount of work which has been done of Agenda 111, you'll be shocked. I believe you would have been paying regularly. You should have paid about $1 billion, remain only about 700 maybe million. Because the problem is that, as I said, they prepare their certificates, come and then we are paid. If there's no money, we keep it before they are paid. And they've worked more than what we have seen. So we are praying very hard that they will listen to reason and make sure that Ghanaians get whatever they want, so that the reason and then the whole rationale behind Agenda 111 will be achieved, and Ghana will be the winner.
All right. I think Kofi has something to say. Kofi, let's hear from you before we call it fine.
Okay. Hello. Can you hear me?
Yeah, go ahead.
Hello.
Yeah, go ahead.
Okay. Oh, thanks so much. I'm so glad that you've tried to link Galamsey and then the Agenda 111. Very, very. The link is very good. As Tim said, it's something which is going to trend the whole group. Water. We need water to build the people, the hospital, etc., etc. But the problem with Ghana, we keep on saying that don't bring politics. Everything is politics. We just talk about it, we don't know how to go about it. One thing I'll ask you is, the only thing that there's no politics is when Black Star is playing World Cup. Why do we do that? Let us find out why when Black Star is playing, politics go out. Then maybe you can apply that principle to this particular one. The other point is that until we're able to decentralize and give power to the district level, I'm afraid they will still be controlled from the top. You mentioned, as the government is saying that they get the DCs, the chief and the DCs have no power. It's being controlled from the top. And to be able to get these little things like decentralizing here and there with power, redevolution there, I'm afraid we will really be eating on the tail of the elephant. Nothing will happen. I'm sorry, that's what I see.
Yeah, you are right about that, but Dr. Sribos made a good statement in terms of what we were able to do on Galamsey, that if we are able to bring everybody together. So there are situations whereby Ghanaians see, okay, let's put politics aside, based on the way the narrative is being crafted in social media or in the news space. So we have to crowd out those political narratives so that independent-minded people can take over and present their thoughts. Okay, let's have the final word. It's almost.
There was a point I was going to ask about when they talked about the missions taking over. The missions, first of all, the missions are complementary ministries' activity. If you look very carefully, ministries are the periphery where the ministry is not stretching there. And as Nsiah pointed out, almost about 90% of funding is coming from the ministry. And one thing of asking the mission hospital is trying to sort of take over all this. Incidentally, all the hospitals are dependent on benevolent donations abroad to build even their own little hospitals. And they have some about 20 years, they have not finished. Now money is not going to come. So that idea should not be entertained at all. That giving the missions to do it, it's out. I'm sorry. They should see to it that how best we can collaborate. That's the point I think about. Please.
Okay, the pension,
and before I end, I'm telling you that there's another group of people you won't forget. There's a group of retired doctors. Almost all the doctors here are on. Retired doctors, they have a very good voice. So every time you try to get a chance, they'll tell you, they'll come to your board. On our platform, we discuss things which are really not coming up there. You see that you have some very good solutions for some of these things. So note it down.
Okay, sure. All right, thank you very much. Let's go to David. David, you have the final word, right? Yeah, go ahead, David.
Sorry, thank you. I thought I was on. Going forward, I think we should have, there should be some core national issues that we should all rally, we should identify and rally around. That should be beyond politics. Things like health, things like the Galamsey issues and co. We should all come together around it. And some of those issues, we should put politics aside and we should all come around it because it affects everybody. And on those issues, as much as possible, we should be nationalistic because it affects everybody.
Sure.
I think that is the way forward. And I will encourage all, the GMA, the civil society organizations, I will encourage them to, I will not say they shouldn't do politics, but on those core issues, they should try and eschew or shed off a little bit of those political leanings and come out strongly with their voice, with much data and research and suggestions like Dr. Sribo did now. I think if he can present a paper to the current government on what he did now, I think it will be very, very helpful going forward, so that it can inform government on what they are going to do. I think this will be very, very helpful. Thank you very much.
Right, thank you very much. So, Dr. Sribo, we've gotten hold of Dr. Nsiah. He is the architect of the Agenda 111. We are trying to get hold of also of Dr. Mr. Honorable Akando. I've tried to reach out to him. It's very difficult, right? But we hope that we'll try to be able to have him probably by next week. And I'll be very grateful to have you over here with him, so that some of the suggestions you are talking about, the pension fund and all these things, we bring all these things onto the ground for them to consider. And if it means that they're going to have a century on the health sector, I think that will be the best way to go. No matter what, that is where we are, and we have to take care of the problem that we have on our hands, right? So on this note, I say thank you.
So I'll be on standby anytime. Just send me the link. Let me know where I'll be joining you.
Sure. Thank you very much. Right. So on this note, like I said, Sankofa we're trying to bridge the gap between those on the African continent and those in the diaspora. We don't have any political leanings. We look at the issues and we discuss them the way we are supposed to discuss them, to inform people, for people to be educated, right? So on this note, we come to the end of another Sankofa. We hope to come back next week, Friday. If you are able to get hold of Mr. Akando, we'll be glad to have all of you back over here. All right, so enjoy the rest of your evening. Enjoy the rest of your weekend. Bye from us.
Thank you.
Thank you. Thank you, Dr.
Thank you.
Thank you.
Thank you. Thank you.